fried chicken, mashed potatoes, and diet soda? The answer is B. It can't be A because tuna and some other ocean fish should be restricted because of mercury levels. And milk isn't an option because your client doesn't like it. C is too high in fat, and she probably wouldn't drink a milkshake if she doesn't like milk. D is high in fat, and soda lacks nutritional value. But B has a low-fat protein source, and the yogurt contains calcium. Now here's another one. Which diet more commonly consumed by a Hispanic pregnant woman shows an understanding of the importance of nutrition during pregnancy? A. Tortillas, beans, rice, and cheese. Or B. Tacos dipped in salsa with water to drink. C. A beef burrito, rice, and milk. Or D. A vegetable taco, salad, rice, and milk. A is correct answer because it is a meal with a good balance of protein, carbohydrates, and dairy. It's lower in fat than B or C and more complete than D. While we're focused on essential nutrients, let's consider a common problem you'll encounter in pregnant clients. That's iron deficiency anemia. Diet alone cannot meet the normal gestational iron needs. In fact, iron requirements double to 30 milligrams per day during pregnancy, not only for fetal and placental development, but to supply the expanded maternal red blood cell mass. Since maternal blood volume increases by 1,500 milliliters, the need for supplemental iron is clear. Risk factors for anemia during pregnancy include pre-pregnancy anemia, poor nutritional status, close spacing of pregnancies, multiple gestation, and excessive vaginal bleeding prior to or as a result of pregnancy. Hemoglobin, hematocrit, and serum ferritin levels are the diagnostics used to confirm iron deficiency anemia. A hemoglobin level below 10 milligrams per liter and a hematocrit below 35% reflect anemia. If your client has anemia, she will be susceptible to infections and show signs of fatigue and pallor. During and after delivery, your anemic client will be less able to tolerate blood loss. Without sufficient supplies of iron, she will have increased risk of postpartum hemorrhage and other infection. Other maternal risk factors are congestive heart failure during labor and poor wound healing post-delivery. Fetal and neonatal problems include increased risk of preterm birth and small for gestational age infants. Your intervention for anemia include education about iron-rich foods such as fortified cereals, enriched breads, liver, meat, dried fruits, green leafy vegetables, and legumes. These food sources are especially important for women who do not tolerate iron supplements very well. Reinforce that iron is best absorbed on an empty stomach, and that is also taken with a rich source of vitamin C, such as orange juice or tomato juice. Make sure your client understands that milk inhibits iron absorption, so suggest taking iron with other fluids. A common side effect of iron is constipation, so encourage a diet high in fiber and fluids. Iron supplements also turn the stools black and can cause some gastrointestinal upset. Warn your client about these effects so that she will not be alarmed by them and abruptly stop taking the iron. The usual prescription for anemia is either ferrous sulfate or ferrous gluconate. These medications are taken orally. However, in rare cases, when they are not tolerated, iron dextrin complex can be given by injection. What danger signs reflect the complications of pregnancy? Although pregnancy is considered a healthy, normal condition, complications do develop. They should not be confused with the expected discomforts of pregnancy, such as varicose veins, heartburn, and constipation. Danger signs are ominous developments that you must teach your client to report to the healthcare provider without delay. They include vaginal bleeding in any amount or of any color, rupture of membranes, severe persistent headache, visual disturbances, edema of the hands or face, abdominal pain, epigastric pain, elevated temperature above 101 degrees Fahrenheit, that is 38.3 degrees Celsius, with chills, painful urination, persistent vomiting lasting more than 1 day, and a significant change in or absence of fetal movement for 6 to 8 hours.
My wife's pregnant and she's bleeding.
Is it Frank bleeding?
Frank? No, Tom Miller.
Not everyone is familiar with medical terminology, especially in a stressful situation. Let's try that again.
My wife's pregnant and she's bleeding.
Is the blood bright red or more of a brown, dried color?
Any of these danger signs could mean a serious problem for your client or her fetus. Vaginal bleeding could mean a placental problem. Severe headaches, epigastric pain, possibly a sign of an impending seizure, edema of the face or hands, and visual disturbances are signs of pregnancy-induced hypertension, that is worsening. Painful urination could mean a urinary tract infection that might cause preterm labor. And an elevated temperature could mean an infection within the uterus or amnionitis. A potentially serious complication is hyperemesis gravidarum, or severe vomiting during pregnancy. The cause is unknown, but it can create problems early and throughout pregnancy. Typical symptoms are persistent uncontrollable vomiting, rapid pulse, decreased urinary output, low-grade fever, and weight loss. Complications include dehydration, electrolyte imbalance, severe weight loss, and metabolic alkalosis. Diagnostic tests that reflect severity and guide the management are hematocrit and hemoglobin, serum electrolytes, and urine acetone and protein. Your goal is to control vomiting while maintaining a nutritious diet. Suggest that the client avoid spicy and fried foods and eat at least 6 small meals a day. Suggest eating dry crackers before arising to prevent nausea and vomiting, and sitting upright for 30 minutes or more after eating. In extreme cases, the pregnant woman might need tube feedings via a nasogastric tube or parenteral nutrition. Another serious complication is pregnancy-induced hypertension, or PIH, also called preeclampsia. It is characterized by elevated blood pressure, edema of the hands and face, and proteinuria. PIH is more common among primiparas, women who are younger than 20 or older than 35 years of age, women who have chronic hypertension, diabetes mellitus, or renal failure.